Good evening, sir. Good evening, respected
Good
seniors.
evening.
Am I audible, sir?
Yeah, you are audible. Go ahead. What is your topic?
Uh, my topic of presentation is Fink effect, sir. Before going to the topic per se, I would like to describe about some definitions and two laws. Initial thing is a partial pressure. Any mixture of gases in a closed container, each gas exerts a pressure proportional to its fractional mass. This is called partial pressure. There are two laws pertaining to this gas in a mixture. First one is Dalton's law, which states partial pressure of each gas in a mixture equals to total pressure of entire mixture. And the next one is Henry's law. Amount of gas dissolved in a solution is directly proportional to the partial pressure of gas in contact with the liquid. Next comes the partition coefficient. Partition coefficient is the ratio of two solute concentrations at equilibrium, that is at equal partial pressure in two separate but adjacent compartments. In case of inhaled anesthetic, ratio of anesthetic concentration in blood to the concentration in similar volume of alveolar gas at the same partial pressures in both blood and alveoli is known as blood gas partition coefficient of that inhaled anesthetic agent. So minimum the blood gas partition coefficient, faster induction and recovery. In increasing order of blood gas partition coefficient, inhaled anesthetic agents values are given as follow. Desflurane has a blood gas partition coefficient of 0.42. Nitrous oxide has 0.47. Sevoflurane has a value of 0.69. Isoflurane has a value of 1.38. Enflurane has 1.8. Halothane on the higher side has 2.4. So minimum being desflurane and the maximum being halothane, which makes desflurane and nitrous oxide comparatively least blood soluble than the other inhaled anesthetic agents. Also, diffusion coefficient. Diffusion coefficient is the ability of an agent to move within the substance of a membrane. It is similar, the values are similar to that of blood gas partition coefficient, lowest being desflurane and highest being halothane. Now coming to diffusion hypoxia, which is also known as Fink effect or third gas effect. This is first described by Fink in 1955. During recovery from inhaled anesthesia, nitrous oxide, having the low blood solubility than other inhalational agents, rapidly diffuses into alveoli, thereby diluting the alveolar air. This leads to two effects. The partial pressure of oxygen decreases, which leads to dilutional hypoxia. This also dilutes alveolar carbon dioxide partial pressure. So the respiratory drive and ventilatory efforts are reduced. This in turn leads to hypoxia. So this effect is mainly seen in nitrous oxide, which is also observed in xenon. This is prevented. This effect is mainly seen during the first 5 to 10 minutes of recovery, during which the nitrous oxide diffuses rapidly from blood into alveolar air. So this is prevented by giving 100% oxygen with zero nitrous oxide during the first 5 to 10 minutes of recovery, especially in a patient with a compromised lung capacity and previous pre-existing lung diseases.
Very good. So this is another very small short note question only. Fink phenomena or Fink's effect, otherwise known as diffusion hypoxia or anoxia, whichever way you want to call it. This is a process where, as you rightly said, it happens only at the end of cessation of general anesthesia using oxygen and nitrous oxide. But nowadays, with the advent and usage of oxygen and air mixtures, nitrous oxide is slowly being pushed back as a drug which has got a lot of unwanted side effects. So people are now trying to remove nitrous oxide from the anesthetic armamentarium totally. So once upon a time, people were thinking it is impossible to remove nitrous oxide from usage. But now, with the use of oxygen air mixtures, we are able to manage cases without the use of nitrous oxide also. So this phenomena was described in the era where nitrous oxide was very commonly used, and in fact, the uh, which country Dr. Fink, Bernard Raymond Fink belongs to, Dr. Prabha? You know the history about
No,
Dr.
sir.
Fink?
Sorry, sir.
Huh? Sometimes they
No,
ask
sir. I
the
haven't.
history questions also about famous personalities in anesthesia. Do you know anything about the life history of Dr. Fink, whose full name is Bernard Raymond Fink?
Uh, Sorry,
Was
sir.
a,
I haven't
was a
read about
British, actually a British American. He was born in UK but migrated to
it.
US
Okay.
and then became a practicing anesthesiologist there. And he described this during the time when the muscle relaxants were introduced into clinical practice. The British anesthetists were using muscle relaxants extensively for major abdominal surgeries by paralyzing the patient and controlling the ventilation. And they were using only oxygen and nitrous oxide as inhalation anesthetic agents. They were not using mostly volatile, and a little bit of hyperventilation also was included as part of the technique. Especially when tuberculin came into practice, they were inducing the patients with hypentone, which has also come into practice, and then paralyzing the patient by using tuberculin itself, and then intubating the trachea, and maintaining the anesthesia with oxygen and nitrous oxide in a proportion of 33% oxygen and 66% nitrous oxide. That used to be the combination. And at the end of this procedure, when they try to reverse the muscle relaxant, residual muscle relaxant effect, patients have been throughout inhaling only this mixture of oxygen and nitrous oxide. And when spontaneous effort is returning, what happened? There is a mass exodus of nitrous oxide because that is more diffusible than the nitrogen in the air can come and enter our body cavity. As you all know, because we are breathing air, there is a lot of occupation of nitrogen in our body. That is why when you do pre-oxygenation, we call it as denitrogenation also. We are removing the nitrogen which is inhaled by us every day, every minute, every second in our atmospheric air. It forms almost 80% of the content of the atmospheric air. And this nitrogen has to come in and nitrous oxide has to go out. That is the diffusion that has to take place at the end of the anesthesia when patient is anesthetized with oxygen and nitrous oxide. But the speed with which nitrous oxide comes out is much, much more faster than nitrogen can go and replace the body cavities and other areas inside our body. So this mass exodus of nitrous oxide coming out much more faster will dilute the alveolar air. So, and if the patient is getting only room air at the end without 100% oxygen, what will happen? This nitrous oxide will mix with the room air and dilute the 20% oxygen which is present in the atmospheric air and reduce it to 15% or even 12%. So there will be an anoxia or hypoxia. Hypoxic hypoxia will ensure because the FiO2 gets decreased. And second thing is will also dilute the nitrous of carbon dioxide, which is trying to escape out during breathing. And this carbon dioxide level also will go down, and that will also cause carbon dioxide, as you know, is the main stimulus for our respiration. So respiratory drive also will be reduced. So both the effects will take place. Hypoxia will happen because of the dilution, and respiratory stimulus will be taken away because of CO2 dilution also. So these two effects are quite deleterious for patients with compromised lung, as you rightly said, especially in the geriatric age group. At the end of surgery, using general anesthesia, using oxygen nitrous oxide, if you don't give 100% oxygen at least for 3 to 5 minutes at the end of the procedure, the patient is likely to suffer from this particular condition. That is why we always cut down the nitrous oxide before we give the reversal and the spontaneous respiration is resuming in the patient, and then try to reverse him and get him out. And even after extubation, we try to hold the mask for a few minutes with 100% oxygen to avoid this particular problem. But in a healthy individual with a good stable heart and hemodynamics and good lung function, this may not be very clinically significant, but this bears much more significance only in patients, as you said, with compromised lung function or in geriatric patients where normally all the functions get reduced by 1% after the age of 40. So that is what you have to write for this answer. And it is a quite satisfactory answer you have written. Very well done. Good.